This recording started a little bit late, but otherwise, just keep in mind you should know the three cartilages. Everything you know from the previous exam is the same thing, but just keep in mind that the topic that's going to be focused on is how hyaline cartilage is used in the development of bone in the fetal skeleton. The rest of them, you just need to know where they exist and you're fine, just like we needed to know for the first exam. Appositional growth was growth along the periosteum, where it grows circumferential lamellae. And when we look at the endosteum, or the inner layer, the medullary cavity, the difference was that osteoclasts increased the diameter by removing bone within the inside, and on the outside, their circumferential lamellae are laid out by osteoblasts, which lay out more circumferential lamellae, increasing the diameter by that means. Now, when we begin endochondral ossification, we can go ahead and get rid of this slide. I'm going to go ahead and remove this. But when we go straight to endochondral ossification, what we see is that we begin with our cartilage. And these chondrocytes get large, and then they begin to calcify. And what we see is what we refer to as a bone collar being made. And this bone collar only surrounds the diaphyses. That's the only place you find it first. It's where you get the first bit of bone cells being laid out by osteoblasts. And when we look at this inside, you can see that now this entire center is completely replaced from cartilage to having what we know as spongy bone. And so osteocytes or osteoblasts more than likely, laid out what we refer to as the primary ossification center. That means that this is the first site where a real bony matrix was made. Even though we had our bone collar made, technically this is still considered our primary ossification center. This is going to be the site where expansion or appositional growth is occurring, and our medullary cavity can increase in diameter. And we see that we started off with nothing but hyaline cartilage, and then we ended up replaced with osteoblasts, replacing those chondroblasts and chondrocytes to actually create what we know as our medullary cavity, which is now going to be mainly made of bones. Something to draw here is that when we saw our bone collar, you can see that this is the beginning of where we had some vascularity go into these bones, into this bone model. And so once the blood vessel innervated fully into the medullary cavity, the ossification center could begin. As that ossification center increased, the vascularity increased throughout the medullary cavity. And then we get our second major event or clear event, is that we see our secondary ossification center, which is going to form in the epiphyses. Remember that you have two epiphyses, one that's going to be proximal and one that is going to be distal. And so these secondary ossification centers are going to occur. The same thing that happened the first time is going to occur, is that the bone is going to expand within the epiphyses, and then we end up with more bone, spongy bone within those segments. Now, what is, I think, a little bit more difficult to understand is what we encounter here in the ends here. We have something called the epiphyseal cartilage, and you will have this leading all the way up until adulthood, and this is how your bones grow. You have to imagine to yourself that this is on there twice. You have this structure that developed out of this on this end, and then you also have this develop just like that as well. And so this cartilage, what it's responsible for, that if we examine it, is that you still, until you reach adulthood, you will always have chondrocytes along these little areas here that are building bone, and they are building it in both directions. So they are building bone this way, pardon. They are building bone, which way? Yes, that's right. They are building bone, in the opposite way. And then so they're building, chondrocytes are getting their chondroblasts, and those chondroblasts are building up, and then what happens when they get trapped inside? They get trapped inside of a little lacuna, but you will still have chondrocytes, even though over here you have osteoblasts and osteocytes doing all the work. But for the most part, until you finally stopped puberty, your chondrocytes are going to be trapped in layers in this region, and they're going to be mitotically active, and they're going to be growing in this direction. And every time they get stuck, they get left behind. And as they get left behind, osteoblasts come into the locations and remove those chondrocytes and replace it with bone. So as the chondrocytes are building upwards, the bone cells are following upwards in order to replace that cartilage model that was there with bone material, with osteoid material. So cartilage goes up, bone follows it, and when you get to adulthood, when you stopped growing, the cartilage disappears entirely. And then what we see is something called an epiphyseal line, which is a remnant of this cartilage. So until adulthood, you have that cartilage growing, and then eventually you stop puberty. And then the cartilage that's left over here will eventually disappear and be replaced with bone, and you no longer can grow in height because the cartilage, this little segment of cartilage that was responsible for growing on that to that end, and the little bit of cartilage that's going to be responsible for growing to this end, has finally been your growth hormones are not the same when you're out of puberty, and so the epiphyseal plate solidifies, and then you see a little remnant of it here. And so sometimes this is referred to as epiphyseal plate or epiphyseal line, and that's sort of a remnant of that cartilage model serving as a scaffold. And we'll also notice that when we started here in our ossification centers along the epiphyses, that on the surface, some of the cartilage was sequestered onto the surface, and then you can see a remnant of that cartilage stays on bones even to adulthood. So this is why we even say that hyaline cartilage makes up articular cartilage, because this is what prevents wear and tear from a bone, the contact from bone to bone. So it comes from the same source. And that's why we say hyaline cartilage is used to model bone, and it's also used to form protective coverings around bones as well. Ask away. Ask away. Almost the same thing. So when we look at joints, you don't have any in your lab manual. Let's see. I'm going to say kind of and no at the same time. I'll show you why. No, wrong thing. Oh, what am I doing? Here. Okay, so when you examine two bones, like for example, here's our femur, here's our tibia, right? Our femur is going to be that thigh bone, tibia is going to be what we know as simply as our ankle bone. And so when we tear something, our ligament, this is going to be dense, regular connective tissue made by fibrocytes. That's going to be attachments that are from bone to bone. That's a ligament. Now, articular cartilage is the one that wraps around here. This is made by chondrocytes in development. This is going to be made by cartilage. This is made by dense, regular connective tissue. Two entirely different cells make it, chondrocytes and fibrocytes. And so when we damage joints, all our joints are typically like little pockets or circular cavities like this. Outer ligaments, you can have ligaments that go on the outside, and sometimes you have ligaments that cross through the center of the capsule. And then we show an actual knee joint. Everything you're seeing here are ligaments. Some of them you may have heard before, like ACL, right? That's a very common one. Those are all ligaments that are tearing dense, regular connective tissue. When we talk about cartilage, that's going to be just a covering on the bones underneath it, like this. And they're in contact, but they're part of the joint, but not the same thing as when you damage a ligament. Not the same thing.
So it's sitting right in between.
sitting right in between, and then the ligaments hold the bones together. The cartilage on the surface protects friction between the two. I always like to think about it like, you know, the AirPods, they come with a little silicone little case so that when you put it in your pocket it doesn't scratch, like your keys don't scratch it. It's the same concept. It's like to protect the surface of the bone. Ligaments, they're more about like a rope holding bone to bone together. A little different. But in some instances, you won't even be able to tell the difference. Like even your tooth is connected by connective tissue, but almost in the same way the cartilage is. But not. We'll learn that later. And so just to summarize now, when we look at this image here, this translates over to this, like what the directionality of growth is. That if we look at our chondrocytes, our chondroblasts have always been mitotically dividing upwards toward the epiphyses, but then they get stuck. When they get stuck in their lacuna, and these are all cartilage cells, chondrocytes. But as you're growing, the bone cells, right, our osteoblasts, they're migrating upwards, and as the chondrocytes degenerate, they're replacing it with bone, until you finally reach the stage where you no longer are growing and the cartilage is completely gone and the bone has finally caught up to that cartilage. And these steps are written out for you here, okay? Otherwise, they go together. And I have a little video that comes with this little publisher too as well, and I'll post it underneath so you can see a little active video that makes it a little more interactive. Next. Now, this type of bone growth is going to be more relevant for flat bones, the mandible, these bones that have sort of flatter ends to them, parietal, occipital, frontal bone. That's what makes this growth different, is that you're not really going to encounter this in long bones. You're going to find it mainly in our flat bones. And so when we look at our diagrams or our images here, we start off with mesenchymal cells. Mesenchymal cells are special types of cells that can turn into any type of cell. And so in this case, they're going to turn into our osteoblasts. And our osteoblasts together, when they unite, will make little centers called ossification centers. Just like the previous slide. It's like saying a center where bone began, or bone's going to begin to grow. Like this was our primary ossification center. Here was our secondary ossification center. And this has the same spirit in that the osteoblasts create little centers that are going to create, or where bone is just going to expand from. And mesenchyme is the cell responsible for generating our osteoblasts. They differentiate into osteoblasts. It's like saying these are our osteoprogenitor cells. It's kind of the same thing. And the material that bone lays out is osteoid. Remember, this is going to be the material that osteoblasts lay down before it gets very calcified, very tough material. And so that's going to be the first bone matrix that you encounter. What we encounter a little bit further down the line, our step 2, is that blood vessels really begin to innervate. It kind of sounds similar to our previous step, that blood vessels really play a major role in that the bones want to establish some vascularity. And this is the stage where the blood vessels are going to be providing an excess, or the amount of nutrients and oxygen and gases required for mitosis to keep dividing and producing collagen, and providing the calcium that they need to put onto that collagen to make it turn into bone-like material. These little tiny pointier regions arise, and these are called spicules, and that's what really defines this region, is these little spicules that arise from further development off of those ossification centers. The next segment is that you'll see that those spicules, much like fingers, will eventually wrap around these blood vessels and envelop around them. And so the blood vessels get trapped within the bony matrix. And then this, in turn, after more growth, we see that our osteocytes are no longer in open areas. They're going to be trapped within a harder matrix. So our osteoblasts became osteocytes, being trapped in little cavities called lacuna. And then we have osteoblasts sequestered to the edges of these regions. And then finally, our blood vessels are trapped within to provide nutrients to all these trapped osteocytes, and then they're going to have caniculi that allow exchange of materials once the blood vessels have dropped it off through their capillaries. And this will form what you know as spongy bone in your flat bones. And the outer edges, just like before, will be compact bone. So this sandwichy region, it'll look just like this. You end up with compact bone on the outside, compact bone on the outside, and then you end up with spongy bone. And you can ignore this word, just spongy bone works just fine. And so you can see that compact bone will be on the outside and spongy bone will stay in the center. But otherwise, this is the word to describe the development of flat bones like parietal bone, occipital bone, frontal bone, and the mandible. Otherwise, that's really just what the text is, just mainly a verbal description of what I mentioned. And then to finish up our segment for bone, we just need to go over fracture repair. And so it can be broken down into 4 steps. We have our hematoma formation, a callus formation, spongy bone formation, and finally compact bone formation. When we have a fracture, we form what we refer to as a hematoma, which is going to be, in essence, like what we saw in integument system. It's going to be a large blood clot. And the point of it is to close any more leakage of blood or seeping of blood from open blood vessels. And so the platelets create a clot. And when you look at this clot, eventually this hematoma will form into 2 regions. It'll form into an internal callus and an external callus. External callus and let me make this larger. External callus and internal callus. You'll notice that things begin to change out here, things begin to change out here, and our external callus is going to be replaced with cartilage until it can be replaced with bone. And that stabilizes the outer region. The inside of the callus is going to be made of different, because remember that we do have an orientation. We have compact bone and then we have spongy bone. So our internal callus is more responsible for maintaining the network of the spongy bone. The external callus wants to still be tough enough to withstand the downward compression that your bones have to face every day. So cartilage is more suited to actually replace the outer edge so that there's more integrity along the outer edge faster. And so we refer to that as just callus formation. The inside will just gradually be replaced with spongy bone. The callus on the outside will be replaced by cartilage, by chondroblasts. When we get our spongy bone formation, even though we had 2 different segments for calluses, what your body likes to do is that it likes to lay out a simpler form of the bone. So you can see that the cartilage is then replaced with spongy bone. And that's kind of where that narrative ends. This internal callus has already started to develop spongy bone because it already had the osteoblasts that are equipped to create spongy bone within that vicinity ready to go. But on this outer end here, this spongy bone tissue, or these osteoblasts, lay down spongy bone first before they begin to actually replace it with compact bone. But the only different step is that they needed to add a cartilage intermediate in the external callus. But then afterwards, spongy bone, this is still spongy bone because nothing changes within. But then we see a remnant of it that when spongy bone is produced, you can always see the external callus sort of leave sort of what we refer to as an external callus, because you just see it protruding out of the bone. And it's sort of because the bone never heals exactly the way it was supposed to. And if you give it enough time, over a few years, you can expect that this will shrink in size. And it would only take like x-rays to really see a denser region on the compact bone. But until then, you can see the external callus, and it just shrinks over a few years. And now some motions we gotta learn. And before I let you off into break, and this is what I want you to hold on to coming into lab, like after the break, is I want you to think about these motions, even if you just have your notes, really just want to be looking at them and then solidify this today, because it's easy, but it's easy to forget as well. So for example, we're going to learn some words like flexion. So when we look at our diagrams, we already kind of know what these motions are. Our limbs have movements around our joints. Like, for example, flexing at the beach is the best way to remember. When you flex at the beach, what do? You do this, right? You flex at the beach. This bend is flexion. And the opposite of this is called extension. So what would it look like if my fingers flexed? Exactly, like this. If I extend those fingers, like this. And if I flex my wrist, what does that look like? Like this. If I extend my wrist, like this. What does hyperextension of my wrist look like? Like this. Right? So again, flexion, extension, and then hyperextension. And you can do it in 4 locations on your limb: fingers, wrist, elbow, and shoulder. So if I flex my fingers, if I flex my wrist, if I flex my bicep, if I flex my shoulders, that's it. So you see how they all sort of curl like a rug. Like a rug, like if you're rolling up a rug. That's what flexion is, like rolling it up. And so extension is undoing it. Okay, that's a simple one. And so flexion is always that bend, but you can do flexion of a lot of things, like my neck. What does flexion of my neck look like? This is flexion of my neck going down. What does extension of my neck look like? Going back up. What does hyperextension of my neck look like? Doing this. Right? So there's a direction. When you decrease the angle, flexion. When you increase the angle, extension. And then even the limbs can do a little bit of extra hyperextension. So this is flexion of my shoulders, flexion. And then if I say extension, but then if I say hyperextension, extension, right? I go further back. And so these are the motions that we're learning. You can do it with your legs as well. So we pay attention to the knee as well. If you notice, there's a pattern or a connection between this and also the knee, where it does this. So when we're skeletons, our bottom end reverses from the top. That's why this goes forward and this one goes back, because it's the same motion, but our skeletons get reversed when we're in the womb. And so flexion of the knee or the leg can do the same thing. If I tell you to flex your toes, what does that look like? Right? You're like sort of squeezing your toes like this. And then if I tell you to flex your knee, then you're flexing this knee. If I tell you to extend it, you're extending it out. If I tell you to flex the thigh, you're flexing it. You're extending it, you're bringing it right back down. And then so these motions are all going to sound similar throughout. And today we have to learn muscles. And when we learn muscles, we have to learn what they do. So learning these words is essential. And next one. Oops, wrong way. Sorry. Went the wrong way. Dang it. Where did I go? Here we go. And so when we look now at another one, abduction and adduction. Abduction, ABD, and ADD. This one's with a B, this one's with a D. And so when we say abduction, you're thinking about a jumping jack. The top part of a jumping jack is abduction. The opposite, adduction. If you have trouble remembering that, I use alphabetical order. B versus D. B comes first in the alphabet, so I start superior and inferior. So abduction, adduction. So that's why I always remember abduction and then adduction. If that one's not helping you, you can think of add, like addition. So when you bring it to your body, you're adding it to your body. Adduction. And the opposite is abduction. And you can do it for your hands as well. So not only can you do it on the shoulders, abduction and adduction. If you just look at the hands, If I want to abduct my thumbs, it's going up. If I want to adduct them, it's bringing them down. So we're going to see these terms come today when we learn motions. So as you're taking your lunch, I want you to just be reviewing these because you can get this out of the way today and it'll be easier to understand muscles. So with that, we have two more. We have circumduction, which is a circular motion, and then we have rotation. Rotation, lateral, this is the easiest way to explain rotation on the limb. This is medial rotation, like giving a hug, and then letting go of that hug is lateral rotation, going towards the lateral end. And then there's lateral and medial rotation of the legs. You can do the same thing. If you're gonna, there's something on the between your feet and you want to hug it with your feet, that's medial rotation. You want to let go of that hug, you rotate these out, and that's going to be lateral rotation. So it's just me doing this or this. And that's really it. All right. Take your lunch break. I'll see you all at 11:35, and I'll be spending